This particular webinar is going to be recorded, so just be conscious of that. And thank you for sharing your location as well in the chat. Glad that we were able to get as much folks in as we possibly can. I see quite a few people from across the state of Washington. That's delightful. So, why policing and mental health illness and homelessness is our topic for today. I think if you've been in tune to the news, there's tremendous amount of instances and lots of unfortunate instances where the impact of policing as a first option for managing a mental health crisis has had really detrimental and oftentimes perilous outcomes. And we want to take a look at why we've gotten to that point where that's the scenario, and what are some of the recommendations for addressing that particular concern. So the hope is today we'll be able to take a conscientious look at the evolution of policing in mental illness and homelessness, and what has been some of the interventions and the potential recommendations for addressing this particular challenge in our field. And absolutely, the presentation slides, I will make sure that I offer you a link to the presentation slides before we end and wrap up today. So certainly, please remind me for that. So welcome. Today's meeting is hosted by the Division of Behavioral Health and Recovery through the Washington State Healthcare Authority. And this is an interactive meeting, so I'm glad we're able to have the chat option. And I would certainly like you to share your experiences and share your feedback, particularly regarding this subject. The slides and recording will be sent to you subsequently. I'll make sure I give you a link to the recording, and subsequently, for the same email you register will be the email to which the recording and the slides will be sent subsequently, but I'll make sure I give you the link today as well so you can access it. So fantastic, let's get rolling. The usual housekeeping, I put in the chat the link to information and the call-in information in the event that you lose the video option. You'll have the option of using the audio call-in. And Yudi, with regards to a certificate, we'll certainly talk with the folks at DBHR with regards to how they do that from Washington State. I don't know if you know, we are contracted by DBHR to present the this particular learning community. We are part of Rutgers University, and as such, we are contracted. So I'm not certain how the certification for this particular webinar may go, but we'll talk to Kimberly about that. So policing and mental illness and homelessness, oftentimes, like I indicated, has had some harmful and deadly outcomes. As a matter of fact, it's estimated that more than 2 million arrests in the United States each year involve people with serious mental illness, half of which are homeless at the time of their arrests. And as a result, what really comes from that is that untrained and unprepared stakeholders in the criminal justice system, i.e. police and police officers or law enforcement officers, are forced to navigate an increasingly scarce system of care for people with mental illness. And literally, the penal system and jail have now become a place where a disproportionate number of people with serious mental illness spend a significant amount of time as a consequence of those arrests. And their ties to the community are often severed subsequent to those arrests. Their treatment needs are often unmet, and their illnesses are made worse. And this was certainly lamented by Leafman in 2009, really establishing that significant data and harsh realizations about the relation or correlation between law enforcement involvement in mental health crisis as a first point of entry or first point of intervention. As a matter of fact, the National Alliance on Mental Illness believes in minimizing the justice system response to people with mental illness while ensuring that any interactions between the police and folks with serious mental illness in the course of a crisis in particular, really helps to preserve health, well-being, and dignity. And NAMI really opposes all laws and public policies that perpetuate the criminalization of people with mental illness, because a lot of it stems from that perception that folks with mental illness are prone to criminal behavior. So we'll talk some more about that. Is that familiar to everyone? Have you seen the impact, or you have a sense of the impact of policing mental illness, and particularly those who are homeless, that level of interaction and the outcomes? And Christine says, yes, absolutely. Yes. Wow, that's great, Jacob, to know that you're a DCR. Yes, see it all the time. And it's one of those unfortunate situations where it's paved with good intentions. Certainly, we're not here to demonize the police department. Certainly, they have the gallant effort and oftentimes ill perceived role in this particular instance. We certainly are aware that the police force is not trained, is not equipped to deal with mental health crisis in a manner which it is currently doing. I think it's overwhelming, it's beyond their scope, but oftentimes that's the first point of interventions. And I agree, Janelle Lewis, that the laws are harmful to the homeless, particularly in urban areas, in urban cities. So we'll talk some more about that, and hopefully we'll gain some insight as to why that is. So what are our learning objectives for today? We want to examine the factors that contribute to the criminalization of mental illness and explore police discretion and bias, because that has a lot to do with how the decisions are made, why the decisions are made to actually enforce criminal laws, as opposed to really guiding, leading, and serving as a conduit of health appropriate care for folks with mental illness, particularly those in crisis. We also want to review recommendations for decriminalizing mental health crisis and facilitating a path to recovery while preserving health, well-being, and dignity of those, particularly those in mental health crisis, who oftentimes also happen to be folks who are unhoused or homeless. And Christine says the impacts of sweeps is devastating. Absolutely, that rounding up of folks has not worked. And yet it's often the go-to, the default approach when things appear to be out of control in terms of what is called vagrancy or loitering in that regard. So we'll talk some more about that. But those are our objectives today, really to take a look at how we got to this point, why, and there's a sense of the approach of criminalizing the mentally ill or those who are often mentally ill and homeless, and how police discretion and bias comes into that, how that play out in that role, and what are the recommendations for really approaching that with dignity and more of a path to recovery than actually lending those circumstances to incarceration or criminal outcomes for folks who are in the throes of a mental health crisis. So I want to take this opportunity to share with you a video that really gives us some insight into the use of force in response to mental health crisis and folks who are homeless, and how it really resonates with this particular subject. So
Fairfax County Police
let me know if
released
you're able
camera
to hear the
footage
video.
showing one of their officers shooting and killing a man who was in the midst of a mental health crisis. A warning, some viewers may find this footage disturbing. Aaron Lynch was shot and killed inside his McLean home here last month as he advanced on officers while swinging a bottle. His parents called the shooting unjustified. News 4's Paul Wagner has our story.
Sometime after 8 o'clock July 7th, 3 officers, all trained in de-escalation and crisis intervention, entered the home on Arbor Lane in McLean and immediately encountered Aaron Lynch.
Aaron? Hey, bud, down. Whoa.
Lynch says nothing before the encounter escalates quickly.
Put it down, wait on. You just put it down, son.
Police say Lynch has an African mask in one hand and a large bottle in the other. He is not responding to the officers' commands. They fire their tasers. But instead of stopping Lynch, he continues to advance. Police say swinging the bottle, and one officer fires 4 times. Lynch is pronounced dead at the scene.
Can't say it enough. Any use of force that's depicted on video, particularly any deadly use of force, certainly is tough to watch. It's tough to watch. And it's tough for us to watch. It's tough for you to watch. But it's even tougher for the family to watch.
Footage the family, Chief Davis says, has already been able to see. In a statement released today, Lynch's parents, Pat and Kathy, said in part, "Our son Aaron was experiencing a severe mental health crisis on July 7th. He was scared and asked for both of the 911 calls that were made that day. We believe that the 3 police officers who answered the second 911 call could have and should have handled this far differently. To respond to Aaron's mental health crisis by shooting him at all, let alone multiple times, cannot be justified." Questioned why officers didn't retreat or try to tackle Lynch instead of using deadly force, Chief Davis said,
Police officers, their presence and then their repeated demands for Mr. Lynch to drop what he had in his hands amounts to verbal de-escalation. And then when the electronic control weapons or the tasers were used, that less lethal force, I think, is another progressive effort to use less than deadly force to handle the situation.
Now, here's where the family is having a lot of trouble understanding how this was handled by the police, because they said that earlier in the evening, police officers first showed up with a mental health counselor. But then when they were called back to the house, the 3 officers came without that counselor because that counselor was apparently not available. And they went inside the house to confront Aaron without him. And that's where the parents are troubled. Reporting from Fairfax County Police.
And that's, unfortunately, that is certainly so commonplace. It's hard to render a rational comment that lends itself to even seeing that situation unfold in the manner in which it did, without having, a significant position on either side. But I certainly want to hear from you as to what you think that speaks to, and where, the gaps are. And I see a number of folks already really commenting already. Christine said, demands are not de-escalation. It's so mind-blowing when you hear the term de-escalation being used in that manner for those of us who work in mental health field, to understand how you can relate de-escalation with someone who may not even be in a state in which they can rationally or clearly understand your commands. And it's commands de-escalation. But certainly I want to hear your feedback. It says, these men were clearly not properly trained in de-escalation. It's peculiar because it's a yes and no in that instance. They're trained in de-escalation, but is that concept of de-escalation appropriate for someone in a mental health crisis, or simply de-escalation as it relates to a normative criminal act? You get my dilemma there? Because that may be the training for a police officer in that regard, but that is certainly not appropriate, clinically appropriate for a person in a mental health crisis, where de-escalation has a different set of skills and approaches. Crisis is not a de-escalation. Tasing someone is not de-escalation. And notice the use of the euphemism of electronic stuff, not a taser, wasn't mentioned in that manner. But it's so peculiar in that sense, because the police officer was really functioning based on his training, but he was certainly outside of his skill set, outside of his scope of expertise in that particular setting. And Felicia says, I think it speaks to the stigma of mental health and how often or other will walk in with a heightened sense that leads to reactive, absolutely de-escalation. Just simply walk into that scenario with a gun and a badge and a uniform invariably escalates the situation. Law enforcement's definition of de-escalation is all about de-escalating a risk to their safety and not the safety. That's a great point, Christy. Absolutely. They are training shoot first, ask questions later. There's a lot of caveats. There's a lot of variables here that just don't match the scenario. Gina says the threat was not one that should have required deadly force. Internalized threats meet, yes, deadly force when not necessary. The idea that initially they went in with a mental health specialist and then the second time did not speaks to the fact that obviously there was an understanding that there was a need for someone trained in that particular field of intervention in the first instance. The second instance was just the natural response without that expert guidance. It's that concept of, we expect a nurse to be trained in nursing skills, right? We don't expect them to step into a medical situation outside of their scope of expertise and training. Safety for the officers and that's what the supervising officer relayed, that this is their manner in which they handle business. When someone poses a risk to the officer or the public, their efforts are to remove that risk or to drastically and rapidly reduce that risk. That's not appropriate for a mental health situation in many regards. Because in essence, mental illness is not a crime. However, contact between law enforcement and people with mental illness is all too common. Often these interactions include a person in mental health crisis, ironically, and the situation can escalate, resulting in the use of force, which is evident there. Estimate shows that people with serious mental illness are over 10 times as likely to experience use of force in interactions with law enforcement. And this kind of disproportionate impact is partially due to how officers interpret symptoms. For example, experiencing a mental health crisis, for someone can appear, when a person is in that state, they can appear hostile or resistant, or the symptoms can interfere with their ability to understand and respond to commands. And tragically, the use of force can become deadly, as it was demonstrated there. And that's close to my heart because I've worked in Virginia, Northern Virginia, for an extensive time in intensive community treatment, and I've seen that happen more often than it should.
Fairfax County Police today released.
It was important to share that element of it, to give you an understanding. And Jacob Dolan says, I work in the courthouse now and I escort all my heavily symptoms clients through security due to this. Just think of, things going off, officers, approaching you in a way can be perceived as threatening when you are in a state of mental health despair or crisis. So why is there the criminalization of people with mental illness and homelessness? How did that really unfold? Historically, when deinstitutionalization took place in the early phases, it created a situation where these people were basically emptied out of the state hospital, put into the community with inadequate services and resources. And oftentimes, severe mental illness relegated a lot of those folks to poor neighborhoods with poor outcomes because there wasn't the level of support and treatment available for folks. 20 to 25% of the homeless in the US have a severe mental illness of some sort. That's what the research shows. And oftentimes, inadequate long-term care options is a situation for most folks. A lot of the folks who were basically put out into the community, when these institutionalization take place, there was the expectation that there were community services that were going to be appropriate and adequate to manage that. That was not the case, unfortunately. Resources did not follow the deinstitutionalization path. And the criminal justice oversight of mental illness and homelessness and substance use really took on a life of its own in that regard, because once folks were out in the street, not able to get housing, not able to be appropriately served, oftentimes vagrancy and people out there on the streets was the natural outcome. And that led to the relationship between psychiatric illness and criminality being a topic of intense debate and scrutiny in the recent light of multiple mass shooting in the United States in particular, right? Think of it. There was this false equivocation of psychiatric illness and criminality. There's this concept that they're one and the same, or they feed each other. And that's not entirely true. The research does not bear that out. And oftentimes people who are homeless and invariably oftentimes mentally ill have a disproportionate amount of contact with the police and the court system. And they're charged with minor offenses related to symptoms or untreated mental illness, which further exacerbate their limited access to treatment and care. Great point, in terms of the mental health courts. I think it's more mental health service, wraparound, comprehensive, accessible service, and actually the courts are a combination of them working collaboratively. So there's lots of reasons. So we're just looking at kind of the background as to how this unfolded in this manner. And the jails and prisons really have now become the de facto mental health facilities because of the disproportionate amount of folks who are mentally ill who often get arrested for petty crimes and as such. It then leads to an overflow of folks into the penal and prison system who don't get access to care because, as we know, in the jail system, there isn't a comprehensive amount of services available to people. And the research has shown that 2 in 5 people incarcerated have mental health illness or a history of mental health illness. And a great number of them, more than 50%, 63% of people, don't receive treatment in prisons. And in jails, the number is not very far off. What we sometimes fail to realize, in particular our justice-involved system, is that criminal behavior, particularly people who are mentally ill or homelessness, often have social determinants. They are not simply a relation or an impact or a result merely of someone being mentally ill. But homelessness, unemployment and poverty, harassment and discrimination can lead good people to actually behave in manners and in ways in which they can come into contact with the criminal justice system. Absolutely. Medication and treatment in jail is very hard to come by. So it's important to understand this process, this history, how things unfold. There's prevalent misconception that SMI equals disposition to crime, violence, and aggression. There is this misnomer that if people have severe and persistent mental illness, somehow they are prone, they are literally expected to be violent and aggressive and have criminal tendencies, which is in no way true. We also have to look at how the media portrays people with mental illness. Oftentimes, people are perceived as crazy, out of control, violent, aggressive. There's also the reverse concept where oftentimes we have people who are purely engaged in criminal behavior for criminal purposes with criminal intent, who often use the false label of having a psychiatric illness to excuse their criminal behavior. And that then further exacerbates people's fear and misconceptions about mental illness. And there's, as we know, pervasive bias in the criminal justice system that can result in longer jail times for people with symptoms of mental illness, which is often misinterpreted as antisocial or criminal behavior. So there's that real significant, how to put it? I think the best way to put it, it's almost like a layered wrapping of stuff that further exacerbates the problem, as opposed to addressing the concerns of folks with severe mental illness who may happen to be homeless as a consequence of social determinants, as opposed to just having this mental illness be the sole reason why they're out in the streets, vulnerable to certain actions and behaviors. So it's important to understand that concept. So tell me, what is the police and justice involvement like with your clients? What do you see out there happening? I agree, Jacob Dolan. Oftentimes, trauma is an underlying, variable or impact on all of this. As we know, no one goes out there asking to be mentally ill. And not all folks with severe mental illness in particular have some personality and predilection to bad behavior. Oftentimes, a lot of those actions that result in people coming into contact with the criminal justice system is consequential to people not being able to manage their illness very well or access treatment. Just think of that in terms of what involvement your clients currently have. And we want to take a look at the quality of life policing and how disproportionate it is to certain communities, because that impacts also the rate in which people come into contact with the criminal justice system. So we know that marginalized community oftentimes folks in margin get disproportionately searched, questioned by the police. They just oftentimes have so much negative involvement with the police that it often leads to really less than collaborative and friendly engagement. And Kisha says, negatively, the police are slow to respond when called. They get frustrated with our clients in the hotel being called there. Absolutely. And that's unfortunate because the police consider that not to be a priority. And then when it actually becomes a priority, it often becomes a crisis that they're not able to manage. So there's that, once again, causal and then exacerbation of the same issue. We have evidence that suggests that the aggressive policing practices have dire implications for public health, oftentimes because of those severe and negative outcomes. People can further be traumatized, or their underlying condition can be exacerbated. So it can also lead to people having exacerbated display of mental health symptoms further by their engagement with the police. It can certainly exacerbate, initiate substance use, which further exacerbates someone's mental illness. So there's always all those variables happening in relation to the police involvement with our clientele. And that's important to understand, that kind of policing action has a direct and sometimes substantive impact on the way people respond to the police. Participants in my program who are homeless due to mental illness or substance use, and the police harass them, arrest them, tow the participants' car away. Yes, and we'll talk about why that is in many regards. But there's options. The police can actually have some choices. Oftentimes there's aggressive patrol. And that came from the early 1980s when there was that, what we call quality of life crimes and quality of life policing. The broken windows, order maintenance, or zero tolerance of stop and frisk. So anyone that was out on the street, unhoused or whatever, often became a target of those excessive police interaction. The police also can engage in coercive benevolence or therapeutic policing, where they can leverage a threat of arrest to coerce access to social services and treatment, using that sense of coerciveness into getting people into treatment. But it creates some problems, as we know, because threats don't often work. Sometimes it makes things worse. But there's an alternative in terms of the officer-assisted harm reduction approach. We're using police discretion to channel individuals affected by homelessness, severe mental illness, and substance use towards harm reduction-oriented services instead of the criminal justice system. So the police does have discretion and option It is what they're trained to use or what becomes their default approach that impacts the outcomes for people with mental illness in particular. And it's a shame, because we know everyone think that they're doing the right thing and not often evaluating the outcomes of those actions, because the police are not there to see things. The fourth step removed from their arrest. It's often not known. So it's very difficult to understand the outcomes of that for the police. And that's where the disconnect occurs. Some says there's a couple of police in our community who DO refer people to services. They will also give vouchers for motel when it's cold. Absolutely. The reality, historically, whether the police wants to accept it or not, they have played a role of some kind of social intervention when it regards to people who are unhoused. It's just historically what the police has done. So you can't just disconnect from that. It's part of the role. How they're trained and the attitude they take towards it makes a big impact. What we've seen, though, is in New York City, I don't know how many folks are familiar with that, the new mental health initiative, which we question whether it's a legal response to a mental health crisis. I don't know how familiar you are with the newest mental health initiative in New York City by the new mayor of New York. But what happened is that late last year, New York City Mayor Eric Adams issued a directive that effectively grants police wide discretion to forcefully remove any person who appears to be mentally ill and displays an inability to meet basic living needs from the streets and subways and transport them to hospitals. Just imagine giving police that kind of discretion without any additional training or expertise to make that determination. Could you imagine being asked to determine whether somebody appears to be mentally ill and whether they display the inability to meet basic needs, and your alternative, your responsibility, is to basically force them off the street into the hospital? And often we know most folks are not going to go gently into the night when approached with that attitude. So imagine what that lends itself to. So basically, it's an expansive extension of the discretion of the police to remove and hospitalize people who appear to be mentally ill. And the evidence has not shown it to her. It's basically further criminalize people with mental illness. And the police are ill-equipped to assess for mental illness. We all know that. And yet they're being asked to do that. And it's resulted in a lot of harmful and sometimes deadly outcomes. But it's important to know, because we have questioned whether this kind of initiative is precedent setting across all the states. And NAMI in particular is keeping a close eye and really testing the data so that it doesn't become a default approach without good research. The question then is, what is shown to be more effective and should be done instead of giving that kind of discretion? What we know is that we need to provide a mental health response to people experiencing symptoms, not a law enforcement response. Mental health crises require mental health intervention, not law enforcement intervention. Because we want to look at solutions, we want to also invest in policies and solutions that are evidence-based and help people with mental illness get on a path to recovery, not get into jail where they're not accessing treatment and then they have that revolving door. We want to increase access to treatment and supports and increase investment in affordable housing, healthcare, and supportive services. And to really embark on and emphasize public policies focused on investing in early intervention, comprehensive community mental health services, and robust crisis response for people, so that there's a reduction in the criminalization of people with mental illness. And as a default, connect people to care. When someone is in the throes of a crisis, particular mental health crisis, they don't need to see someone with a badge and a gun. It has never worked. They need to see a mental health response to a mental health challenge, not a criminal or legal response to a mental health challenge. That's the crescendo from the experts. So just keep an eye out, because this particular initiative, there's a concern as to whether or not it becomes precedent for other states. But be aware that that's what's going on in New York. And I know earlier we talked about over-policing and under-policing. Someone mentioned that. I think Christy mentioned it. We're over-policing. We're really looking at the presence that is so prominent in underprivileged communities. There's disproportionate suspicion and threat of force. There's a lot of petty crime arrests, parking tickets, as mentioned earlier by someone, drug offenses, shoplifting, vagrancy, things that oftentimes people who are generally homeless respond to for survival. More time and energy are spent enforcing minor violations by the police. And this same over-policing in those communities lend itself to under-policing in the same communities. Because what happens is that those police, as mentioned earlier, are often tardy in arresting and prosecuting major crimes. Murder, rape, assault, grand larceny, particularly from people with mental illness, are often not addressed with the same fervor and efficiency. Yet we know, yes, because of the negative relationships or the conflicting relationships that people in the communities or underprivileged communities have with the police, it often leads to detectives not getting information that is needed to solve crimes. So there's lots of reasons how that is impacted negatively. And loss of trust in the police occurs, particularly, and the whole justice system in those communities. So there's a never-ending cycle, because then people, when they don't get the service of the police to help address their trauma and address them being victims of crime, people tend to resort to taking the laws into their own hand and then become victims of police enforcement. So it's a never-ending cycle that really creates major problems and needs to be looked at from more of an evidence-based and solution-focused approach. So what do we know about police discretion? Police have a great deal of discretion. I'm sure you're aware of that. How to respond to 911 calls, when to stop someone, how to approach someone, when to use force and not use force, what force to use, when to officially sanction and charge someone with a crime, put them in front of the courts. Police have a vast level of discretion. What's important to note is how that may impact the homeless and the mentally ill to some degree, people who are experiencing mental illness. Because initiating an emergency hospitalization oftentimes is not regarded to the police as a good pinch or a good arrest, because there's a lot of paperwork that doesn't really result in that person having their numbers up. It takes a lot of energy and effort, and the numbers are not there for the arrest. It's largely unrewarded by the police department, and it's perceived as a sign of the hospital's unwillingness to do something. When the police take someone to the hospital and the hospital says, well, this person doesn't meet criteria. Just simply saying that they're on the streets and acting strange does not meet criteria for hospitalization. It's significant. And Sheng Fang says, hospitals and healthcare systems shall step in as well. A key is to prevent reduced mental health illness occurrence. Absolutely. And Mark Holland says, and how is this going to be paid for? The only response is to the police. We have crisis teams in Vancouver, but their response time can be up to 2 hours. Do we leave individuals in crisis, or do we send the police who will respond quicker? That's a very good question, Mark Holland, and I don't want to disregard it. Like I said, this is not about bashing the police. This is about understanding their role. They're ill-equipped for the role that they're asked to play. We'll look at some of the solutions or some of the recommendations that was led in terms of how do we change what is now the norm that is not working in terms of the police being the first respondent. And it requires both funding, training, a change in the philosophy and approach to doing this. It requires more than just funding. But there is certainly approaches that have been vetted and have shown to work. Police have that discretion to whether they arrest a person or whether they resolve the matter informally. Oftentimes, as we know, police knows the individuals and characters in the community, and they make a choice as to who should be, arrested and who is not. So there's lots of discretion that oftentimes can be good, bad, and indifferent. What's important to note is how both the police and all levels of the justice system review and relate to certain elements. There's implicit bias that is important to look at when you're addressing a circumstance. Misattribution is a particular one. And we think of oftentimes when we look at certain people, homeless or mentally ill, the police in particular, or people in that role, can assume that it's the person's personality instead of the situation. Think of it. It's seldom thought of. Homelessness may actually be the result as to why someone is engaging in criminal behavior, not necessarily that the person is criminal who happened to be homeless. So it can be a misattributing to the person's personality or that person's penchant for doing that, as opposed to all the other variables that may impact the circumstances. That person may not simply be prone to that behavior because they have a maladjusted personality. It may be the impact of mental illness. A person has delusional disorder, paranoid, that results in certain behavior. And then there's disambiguation. The result, when you think of it, when things are unclear and uncertain, there is the tendency of people to default to conscious or unconscious prejudice. And oftentimes that occurs with police. If they get a call saying someone is out of control, the assumption oftentimes there is, if I go into that situation, walk into that house that we saw in the first video, and that person is acting in a threatening way, I'm going to use the force that I was trained to use to subdue that person or to remove the threat. When instead, if you think of that person as, okay, if I hear the call saying that someone is out of control, and ask about, is there a history of mental illness or whatever, to really expand your scope and understanding as to what you're stepping into, it certainly can change that element. So that's just conceptually where we want to go. So I want to look quickly at some of the recommendations, because we've just talked about that. What can the police do? What kind of reforms can it take to really help and support people with mental illness when they approach them in crisis situations? We want to promote and implement crisis intervention teams and co-responder models, where the police is accompanied by someone with mental health training and expertise. The use of officer-assisted harm reduction approach as a standard, not as an anomaly, but as a standard. You go into a mental health crisis with the assumption, and you're looking for ways in which you can help that person get tracked and channeled to treatment and recovery, as opposed to putting that person in handcuffs and sending them to jail. Training police on understanding their own implicit bias and monitor those bias at all levels, so that people are not using that default disambiguation to approach every crisis situation. Train police on mental illness, social vulnerabilities, and crisis interventions that emphasize de-escalation guided by mental health expertise. Not de-escalation based on police criminal responses. Create a comprehensive non-911 option to call, a warm line to call instead of calling 911, and ensure that there's a response to that. Promote citizens' use of the 988 as a viable alternative to police intervention, and increase police accountability, particularly in use of force. And we'll look at an instance here where this is what is a great alternative.
Thousands of police departments across the country use crisis intervention teams to help officers respond to calls involving the mentally ill. CBS News' Deborah Alfarone is in Maryland, where she spoke with one police department recently named the best in the world.
Do you feel like she is a danger to herself or others right now?
24 hours a day.
Get the protective order.
Mental health clinicians answer what's called a warm line inside the Anne Arundel County Police Department in Maryland.
Instead of using the word hotline, we use the word warm line so that anybody can call.
Voted the #1 crisis intervention team in the world, this department says it's putting mental health first.
How can we be helpful to them at that moment while they're in crisis? Is this the one from the other day?
Yeah. Lieutenant Steve Thomas heads up the police side of the unit. Jen Corbin heads up the mental health side.
Officers in patrol can call in for a mobile crisis team. It's their discretion. Anything that's not a traditional crime. It could be homelessness, it could be someone in crisis, it could be a traditional mental health issue.
I'm a 91 radio.
91.
Lieutenant Thomas says this approach has led to less crime and fewer arrests.
You're given an option other than arrest. Plus, it's actually addressing a problem far upstream.
Do you think that this unit saved your life?
Yeah, I know they did. Because like I said, if I'd probably been dead a couple times, and like I said, if not by my hand, then by somebody else's hand.
Samuel Mason says he'd been arrested more than 50 times.
I had an issue, I'm schizophrenic. I thought people were after me.
Then he encountered the crisis intervention team.
Since I met them, I think I had got in trouble one time when I was off my meds. And I ain't been in trouble in like a couple years now.
Right now, our community needs someone that they can call when they don't have confidence in the police. And our job right now here, Steve and I's job, is to get them to have faith in police again.
Answering the call for a crisis of confidence, too.
No problem.
Deborah Alfarone, CBS News, Anne Arundel.
So there's an example of really crisis intervention team really taking that mantle of supporting the police, guiding the police in a mental health, ethical, trained approach to doing so. So all is not lost in the sense that, yes, we understand oftentimes the expedience of calling 911, the police arrives first. We want the police to think about the circumstance, think about what they're stepping into, understand their capacity and their limitations, get the guidance necessary. And yes, we want policies to be put in place that will emphasize funding, training, and expansion of this approach because it works, so that we can not only protect our clients, but we can actually play a role in advocating for more efficacious, more effective approach to helping people in mental health crisis that limits the involvement of the police and criminal justice system that we have shown not to help people, not to work. We can't simply say we don't know how to approach it and we're going to just resolve ourselves to using what comes naturally when there is a proven evidentiary approach to doing it in a way that promotes recovery, supports the dignity of folks who are exposed to these circumstances, and really help our entire community manage a problem that is manageable but challenging. And that's the overarching element here. Because what we've seen is that CIT, it works. It reduces arrest for people in mental health crisis. It increases access to mental health services, empower officers to do their job safely and effectively, which is important. We don't want to take for granted the officer's safety, but we wanted to make sure that they're doing it effectively and supporting the people that they are actually obligated to protect and serve. And we want to improve officers' attitude and knowledge about mental illness with training, and reduce the time officers spend responding to mental health calls, because that's not their purpose. And they should be doing the things that they're trained to do and they're best at doing. And there's a tremendous amount of cost saving. There's Cahoots, which is another mobile mental health crisis intervention team using the same approach that has worked. What we also want to do is expand the use of mental health first aid, which really helps people, and that's families or people who may not be mental health service experts, understand how to approach someone in a crisis. And mental health first aid has really worked well for that. So we talk about really how does it support someone in that particular circumstance, and we've seen the evidence of it. It's really helping someone approaching a psychological challenge or mental health crisis by how you approach that person, listening non-judgmentally, giving support in the interim, encouraging that person to access appropriate professional help, and encouraging other supports during that time. So I hope that we've been able to really look at the historical context of how we got to this point of relying almost extensively and over-relying on the police to intervene in mental health crisis, how we have seen that worked, how bias and the discretion of the police impacts and play out in that role, and what are the recommendations to correct or to make that more effective in approaching both maintaining the safety of the individuals served and the officers, and as well getting the appropriately trained and clinically skilled mental health experts in that particular crisis. Because ultimately the message is, we want to address a mental health crisis using mental health approach, not law enforcement. It has not worked. So I hope we were able to really look at what we know to be the current situation, what we've seen work, so we can ensure that we are doing our very best to support and help people on both sides of that equation. I've put in the chat a link to today's presentation and as well the evaluation. If you can take just a few quick minutes and complete the evaluation, it really informs our future webinars. It really helps us understand what we're doing well, what we can do differently, what subject matters you'd like us to address, because we want to really make this a safe and informed space for you as supervisors in this role to come, get information, to share your expertise, share your experiences, so we can all collectively become more informed in a manner in which we take on the challenging job that we have, but a doable job that we have. So I want to make sure that, let me ensure that you take that evaluation as quickly as you can. And I want to also thank you. We appreciate your time and attention and participation in today's webinar. Please note that the slides and a link to the recording of this session and a wealth of resources will be available to you in follow-up emails. Don't forget to check out Foundation Community Supports newsletter for all things FCS and upcoming training events. And as usual, I thank you sincerely for your participation in today's session and sharing your information and knowledge. And we look forward to seeing you in the series of supported housing supervisors learning community. Our next information to our next session, our next webinar will be available to you soon. So thank you all, and I wish you the very best of the rest of the day and the rest of the week, and we'll be in touch soon. Take good care. If there's any questions, certainly if you have a moment that you have a question, I'll be happy to answer that question if you could share it in the chat. Thank you. Absolutely. Yes. Oftentimes, lack of access to supported housing certainly creates and exacerbates the problem of people not being able to safely manage their illness and stay off the streets and limit their encounters with the police and the criminal justice system.